Let's talk about increased intracranial pressure, one of the most critical neurotopics you'll ever face. When we say increased intracranial pressure, or ICP, we're talking about a rise in pressure inside the skull that the brain can no longer manage or compensate for. Normally, ICP sits between 5 and 15 millimeters of mercury. Once it hits 20 or more, that pressure becomes dangerous. At that point, you're looking at a serious risk for brain herniation, decreased cerebral perfusion, and potentially death if nothing is done quickly. To understand how this works, we need to revisit something called the Monro-Kellie Hypothesis. This hypothesis reminds us that the skull is a closed box. It doesn't stretch or expand. Inside that box, we have three main things taking up space: brain tissue, cerebrospinal fluid, and blood. Roughly speaking, about 80% of the volume inside the skull is brain tissue. 10% is cerebrospinal fluid, and the other 10% is blood. If one of those increases, say from swelling or bleeding, then one or both of the others has to decrease to keep the pressure stable. But if they can't shift fast enough, pressure rises. And when pressure rises, the brain suffers. So what can cause increased intracranial pressure? Trauma is a big one, whether it's from a fall, a car accident, or a blow to the head. Brain tumors or any kind of mass can also do it. Cerebral edema is another culprit. That's swelling inside the brain, which can happen after a stroke, surgery, or infection. Hydrocephalus, when there's too much cerebrospinal fluid, is another possible cause. And of course, we have to mention central nervous system infections like meningitis or encephalitis, and any type of intracranial hemorrhage, whether it's a subdural, epidural, or bleeding deep within the brain itself. Any of these can send the pressure soaring. Now let's talk about the early signs, those little clues that tell you something's going wrong before it becomes a full-blown emergency. The most sensitive and earliest indicator is a change in level of consciousness. That could look like confusion, restlessness, or the patient just not acting quite right. Maybe they're more forgetful. Maybe they're slow to respond or can't follow basic commands. Pay attention. Subtle changes matter. You might also notice changes in pupil size or reaction time. One pupil might start to react slower than the other, or they may become uneven in size, a condition called anisocoria. Weakness on one side of the body, known as hemiparesis, might develop as the pressure starts to affect specific parts of the brain. And then there's the headache, often worse in the morning or brought on by coughing, straining, or sudden movement. These headaches are not mild. They're persistent and can feel like a deep pressure or throbbing pain. As the condition worsens, we start to see late signs, and this is when things really take a turn. One of the most classic and alarming signs is projectile vomiting. This isn't your typical upset stomach type of vomiting. It comes on suddenly, often without nausea, and it's forceful, like a reflex, because the pressure is affecting the vomiting center in the medulla. Seizures are another serious warning sign. As pressure builds and brain tissue becomes irritated or deprived of oxygen, neurons start misfiring. If your patient begins seizing, you've got a new emergency on top of the original one. Posturing is another late and ominous sign. If you see decorticate posturing, that's when the arms flex inward toward the core. It usually means there's damage above the brainstem. Still serious, but possibly reversible. Decerebrate posturing, on the other hand, is worse. That's when the arms and legs are rigid and extended, and it typically signals damage to the brainstem itself. That one comes with a poor prognosis. And then there's Cushing's triad. This is a late and often terminal trio of symptoms that you absolutely must recognize. A widening pulse pressure, where systolic blood pressure rises, but diastolic drops or stays the same. Bradycardia, meaning the heart rate slows down, and irregular or abnormal breathing patterns, which might sound like Cheyne-Stokes respirations or even agonal gasping. If you see this, your patient is heading toward herniation and you are running out of time. If pupils become fixed and dilated, or if the patient slips into a coma, there's a strong chance brain herniation is either underway or already complete. And in that case, the priority becomes immediate action. There is no time for a slow response. This is an emergency of the highest order. Let's shift to how we diagnose and track increased intracranial pressure. Imaging is always step one. A CT scan is usually the fastest and most effective tool to identify bleeding, masses, or midline shifts. Magnetic resonance imaging, MRI, provides better detail, especially of soft tissue structures, but it takes longer and isn't always practical in an emergency. We may also use an EEG, a test that records the electrical activity of the brain, to check for seizure activity, especially if the patient has had changes in behavior, responsiveness, or suspected convulsions. When we need direct measurements, we turn to invasive monitoring. The gold standard is an intraventricular catheter. It's inserted into the lateral ventricle of the brain and allows us to both monitor the pressure and drain cerebrospinal fluid to relieve it. Other tools include subarachnoid bolts or epidural sensors, which provide pressure readings without the ability to drain fluid. Transcranial Doppler ultrasound is used to assess cerebral blood flow velocity, and if we suspect a vascular abnormality, like an aneurysm or arteriovenous malformation, we might need a cerebral angiography. Each of these tools helps us understand what's happening, where it's happening, and just how bad the pressure really is, so we can respond quickly and effectively. Let's talk about what happens when the pressure starts building inside the skull. When you've got a patient with increased intracranial pressure, your number one goal is to protect the brain. That means we're working to reduce the pressure, maintain good blood flow to the brain, what we call cerebral perfusion pressure, and do everything we can to prevent brain herniation. That's the worst case scenario, and we do not want to go there. Cerebral perfusion pressure needs to stay above 70 millimeters of mercury. That number is important because without proper perfusion, the brain isn't getting the oxygen it needs, even if your oxygen saturation looks great on paper. It's not just about the oxygen getting into the lungs, it's about it getting to the brain cells where it matters. Now let's go back to basics. Airway, breathing, and circulation still come first. If the patient cannot protect their airway, we intubate. If they're not breathing well or their oxygen level is low, we intervene. If their blood pressure drops, we address that immediately because we can't afford a drop in cerebral perfusion pressure. On top of that, we're doing frequent neurological assessments, every hour, minimum, because things can change fast. The brain is not a patient organ. It will start shutting down function the moment pressure creeps up, so we watch for those subtle signs and act before it escalates. Now let's talk medications, because this is where your critical thinking really shows. First up is mannitol. Mannitol is an osmotic diuretic. That means it pulls water from swollen brain cells back into the bloodstream to reduce swelling. It works by raising serum osmolality. The higher the osmolality, the more fluid we can draw off those brain cells. But it's a delicate dance, because if we pull off too much, the patient becomes hypotensive, dehydrated, and we're back to square one with poor perfusion. So you must monitor serum osmolality and blood pressure closely. Next, we have loop diuretics like furosemide, also known as Lasix. These help reduce total body fluid volume and can work alongside mannitol, but they waste potassium, and when potassium is off, it throws the whole cardiac and muscular system out of balance. So if your patient's potassium level is low, you might see weakness, arrhythmias, or worse. Now, steroids like dexamethasone are a bit more nuanced. We only use these when there is a brain tumor or vasogenic edema, basically swelling caused by leaky capillaries around the tumor. We do not use steroids for trauma-related swelling. They reduce inflammation, but also raise blood sugar and suppress the immune system. So again, we monitor glucose levels and watch for signs of infection. Let's move on to seizure prevention. If a patient seizes, intracranial pressure spikes, oxygen demand increases, and that can cause secondary injury to the brain. So we use anticonvulsants like phenytoin or levetiracetam to either treat or prevent seizures. If we're using phenytoin, we have to monitor blood levels to stay in that therapeutic range and prevent toxicity. Both of these drugs can cause sedation, so monitor their mental status. Now, don't underestimate the role of a good antipyretic. Fever increases metabolic demand. More metabolic activity means more blood flow to the brain, and that leads to increased intracranial pressure. We give acetaminophen to reduce fever and prevent that chain reaction. You also want to keep the patient from straining. That means no pushing during bowel movements. So we give stool softeners like docusate sodium. It sounds simple, but bearing down increases intrathoracic pressure, which backs up venous return from the brain, and suddenly we've made everything worse. And if the patient is on a ventilator or showing signs of agitation, we may use sedatives like propofol or midazolam, and in some cases even paralytics like vecuronium. These drugs reduce cerebral metabolic demand, helping the brain rest. But they also suppress neurological assessment, so if we sedate or paralyze, we need to be even more meticulous in our monitoring. Now let's shift to positioning and environment. Keep the head of the bed elevated to 30 degrees unless there's a specific reason not to. That positioning helps promote venous drainage from the brain. The head should stay midline, no turning or twisting, because any kink in the neck veins can prevent blood from leaving the brain, and again, that raises pressure. Avoid bending the hips more than 90 degrees, because increased abdominal pressure translates into increased thoracic pressure, which pushes against venous return from the brain. We also avoid neck flexion, coughing, straining, or suctioning unless it is absolutely necessary. Any of those can shoot the pressure up in seconds. Now think about the environment. Keep it quiet and calm. No constant alarms, loud conversations, or bright lights. Cluster your care, but do not overload the patient with back-to-back tasks. Even a routine set of vital signs, a bath, and a wound dressing change can be too much stimulation if you're not careful, and limit visitors or stimulation when possible, especially in the acute phase. Families may not understand, but it's up to us to protect that brain while it heals. All right, let's go over what you need to monitor. Vital signs should be checked frequently. Cushing's triad is a late and ominous sign, but you still need to know it. Widening pulse pressure, bradycardia, and irregular respirations. Temperature must be managed aggressively. If they spike a fever, we use cooling blankets or antipyretics as needed. Blood pressure has to stay high enough to maintain cerebral perfusion pressure, but not so high that it causes new bleeding. Your neuro assessment should include level of consciousness, pupil size and reactivity, motor strength, and response to pain. Use the Glasgow Coma Scale and monitor for trends. If their score starts to drop, you need to act. If the patient has an intraventricular catheter in place, which is the most accurate method of monitoring pressure, you have the ability to both measure intracranial pressure and drain cerebrospinal fluid. That device must be kept sterile at all times because it is a direct line to the brain. Any contamination could lead to meningitis or worse. Only drain cerebrospinal fluid as ordered. Too much too fast can cause the brain to shift and herniate. As for labs, you need to check serum osmolality, sodium, and other electrolytes. If osmolality is too high, you may have overdiuresed the patient. Sodium imbalances, both high and low, can contribute to swelling and seizures. Arterial blood gases must be monitored too. An increase in carbon dioxide causes vasodilation in the brain, which increases intracranial pressure. And finally, keep an eye on blood glucose, especially in patients on corticosteroids. Uncontrolled hyperglycemia is toxic to the brain and increases the risk of infection. Let's finish strong by walking through the major complications you must watch for in patients with increased intracranial pressure. These are not maybe complications. These are life-threatening, exam-worthy, clinical priority issues that every nurse needs to recognize quickly and act on without hesitation. Let's start with the big one, brain herniation. This is an emergency where the pressure inside the skull becomes so high that the brain tissue is literally forced out of its normal space and pushed into other parts of the brain or even through the foramen magnum. And if that happens, we are in a code situation. There are different types of herniation, and you need to know them. The first one is called uncal herniation. That's when the temporal lobe pushes against the brainstem. It can cause a dilated pupil on the same side as the injury, what we call ipsilateral pupil dilation. You'll also see a drop in level of consciousness and changes in respiratory patterns. Then there's central herniation. That's when brain tissue pushes downward from the center, and both pupils become fixed and non-reactive. This is a sign of rapid and severe neurologic decline. The worst of all is tonsillar herniation. That's when the brainstem and cerebellum are pushed through the foramen magnum at the base of the skull. When this happens, you'll see apnea and cardiovascular collapse. These patients are moments away from death unless immediate intervention occurs. So, what are the signs of impending herniation that you need to act on fast? A sudden drop in level of consciousness, pupils that become fixed and dilated, the classic Cushing's triad, elevated systolic blood pressure, bradycardia, and irregular respirations. And if the patient starts showing decerebrate posturing, that extension pattern we talked about earlier, that is a serious red flag. That's the brain's last-ditch scream for help. Another complication is seizures. These can happen from cerebral irritation, whether it's due to swelling, bleeding, or scarring. That's why we often give anticonvulsants like phenytoin or levetiracetam, even if the patient has never had a seizure before. It's called seizure prophylaxis. And remember, status epilepticus, which is a seizure that won't stop, is a medical emergency. If that pressure keeps rising during prolonged seizure activity, the brain will suffer permanent damage. Next up, diabetes insipidus. This happens when there's pressure or damage to the posterior pituitary gland. That gland controls antidiuretic hormone, or ADH, which regulates how much water your body holds onto. When it fails, you lose control over water regulation. So what will you see? A massive urine output, sometimes liters and liters in a shift. The urine is pale and very dilute with low specific gravity. Sodium goes up, serum osmolality goes up, and the patient becomes very thirsty. The treatment is desmopressin, which is synthetic antidiuretic hormone. We also give fluids and closely monitor input and output, electrolytes, and vital signs, because dehydration can sneak up fast and worsen the intracranial pressure. Now let's talk about the opposite problem, syndrome of inappropriate antidiuretic hormone secretion, or SIADH. This time, there's too much antidiuretic hormone being released. That causes water retention, which dilutes the sodium in the body and throws off the whole electrolyte balance. You'll see low urine output. You'll see dilutional hyponatremia, meaning the sodium level looks low, not because the body lost sodium, but because it's been watered down. The patient gains weight, serum osmolality drops, and urine-specific gravity goes up. And here's the kicker. If sodium drops too low, the patient can seize. So we restrict fluids, give hypertonic saline only if the case is severe, and we monitor sodium and osmolality like a hawk. Now let's shift to something just as important, patient and family education. Because what we teach in the hospital doesn't stop when the discharge papers print. Families need to know how to recognize early signs of increased intracranial pressure, like changes in behavior, confusion, irritability, or a worsening headache. They need to understand that activities like heavy lifting, coughing, or straining on the toilet can all increase intracranial pressure and should be avoided. Teach them how to use medications correctly, especially seizure medications, steroids, and stool softeners. They need to understand when to call the doctor, how to monitor for signs of diabetes insipidus or SIADH, and how to keep up with incision care if surgery was involved. And do not forget the emotional toll. Families need support. They often feel helpless. So we involve them in care where appropriate, answer their questions, and make sure they're not left out of the loop. Once the patient is home, they may need follow-up with a neurosurgeon or a neurologist. Rehab may include physical therapy, occupational therapy, or speech therapy, depending on what functions were affected. If the patient had a craniectomy, meaning part of the skull was removed, they may need to wear a protective helmet to prevent injury to the unprotected brain. And finally, provide information about community resources and support groups. Recovery is not just physical, it's emotional too. Let's wrap this all up with your expected outcomes. When care is effective, the patient is alert, following commands, and has a stable Glasgow Coma Scale score. Intracranial pressure stays under 20 millimeters of mercury. There are no seizures, no signs of herniation, and no worsening of neurological status. Electrolytes, blood glucose, and serum osmolality are within normal limits. Oxygenation and ventilation are adequate. The family can explain the plan of care. And most importantly, the patient's recovery trajectory matches what we hoped for, whether that's a full return to baseline or a coordinated plan for rehabilitation or hospice, depending on the situation.